Welcome as people start to filter in here. Just getting ready for what are we in September now? September Fireside Chat. So when Dr. Burker, when's the temperature supposed to start dropping in Texas?
We're still in short sleeves on Halloween around here. So
Okay.
Halloween is gorgeous. So, lots of people probably live in places where you have to put your coat over your costume. We never have that problem here in Texas. So
Yeah,
the
we're
Halloween is typically wonderful still.
out in the Northwest. You can have nice Halloweens, but they're usually brisk. But it's the monsoon that really screws up Halloween when you got to
Yep.
put a rain suit over your kid's costume. It takes the sparkle away from Halloween.
And of course, with the
All
coming of
right.
the school year in the fall comes football. But football in the South is rough in September. So it's still super hot.
Little hot. Are you guys mainly on natural or like the high schools down there? Do they play on turf or are they on natural grass for
Yes,
the most
it's a
part?
good question. It's a combination. It's really 50-50.
Mm-hmm. I My kid plays relatively high level travel baseball for his age category, and it's all on turf for these guys
Yep.
now. And they'll occasionally play on a real field, and a bad hop will happen, and they're all up in arms about their quality of field. I'm like, dude, that's all I played with as a kid was taking ground balls
That's
off the
right.
forehead. But
That's right. We would
different.
spend a half hour before the game, and both teams would go out on the infield picking up rocks for 30 minutes before the game started.
Exactly. Exactly. All right. Well, we're making it to the top of the hour. We'll get this dialogue on your end started maybe 60 seconds from now. So I'll start with introductions. But we took the month of August off. So everyone had a nice little vacation month from the Fireside Chat. Hopefully, it misses too much. But we're back in September and we got a full schedule through the course of the rest of the year here. Joining me today, Dr. Eric Brooker, who many of you, I would assume, have watched his video casts that are out there. I know that I do. Very informative. In fact, I sent my sales team one today that he'd done on kind of the breakout of self-funding across the country. I think that might have been today's repost that you did. But always educational, always entertaining, and the master of the whiteboard. So happy to have him joining us today on our September Fireside Chat, and we'll dive into the. Oh, thanks, Lindsay. Dive into the subject matter here shortly. For those of you that have not attended one of these, it's kind of a casual environment. We like to do a lot of Q&A, and we like to have that Q&A come from our audience. So use that chat function to make comments amongst yourselves down there. But for the questions, if you could use the Q&A tab, I'd greatly appreciate it. I'll ask the questions as they come in, and or when appropriate throughout the course of the broadcast. But it makes it a heck of a lot easier for me to see those when you use the Q&A function. So type them in there. With that, I'll turn it over to Dr. Brooker, and we'll get this thing started. As a forewarning, we're going to wrap this up about 10 minutes early today, maybe 5. We'll see how things are going. But we do have to wrap it up short with some prior appointments. So don't think that your broadcast ended abruptly without notification now. So there we go. Dr. Berger, take it away.
Well, listen, thank you so much, Heath and Six Degrees, for having me. And thank you to all of you for listening. And what is historically, and I'm sure is, the busy season for all of us who work in health insurance and employee benefits. So many of you know who I am, but for those of you who don't, my name is Dr. Eric Bricker, and I'm an internal medicine physician. Originally did my medical school at the University of Illinois and then residency training at Johns Hopkins in Baltimore. And then I actually worked as a hospitalist physician at the Baylor Scott and White Hospital System here in Dallas, where I'm located. And then actually started a company called Compass Professional Health Services. That's a healthcare navigation firm where we grew to about 2,000 employer clients, about 1.8 million members across the country. And we sold that business in July of 2018. And then I was sort of independent, and I left as a result of that transaction. And I was like, okay, well, I essentially was working with brokers and consultants and HR and depending upon the size of the organization, sometimes, the CEO or the CFO. And a lot of them still didn't necessarily understand kind of how healthcare worked. And I'm like, well, I can kind of shoot people straight now because I'm not really beholden to anybody. And so I started making these Healthcare Z healthcare finance videos, and I post them on LinkedIn and on YouTube. And shockingly, they got 2.6 million views last year. So I jokingly say it's probably the most boring topic humanly possible, but I try to make it somewhat entertaining. So some of you may have even watched these videos. So thank you so much for watching those. And then I'm actually the medical director for an alternative health plan for self-funded employers called Coupe Health and SimplePay Health as well. That's kind of a competitor to Surest, if you're familiar with that, from United. So the next slide, please. And so today, we're going to talk about the GLP-1 game plan, perfecting design, care, networks, and sourcing. So you can, so you probably remember in college, you kind of had your 101 classes, and then your advanced classes were your 201 or your 301 classes. So this is going to be your second or third level GLP-1 class. So we're not going to talk about the super basics of GLP-1s because I'm kind of going to go under the assumption that many of you already know kind of the basics, but we're going to kind of go next level in terms of what's going on in the employer space with GLP-1s and what employers are doing with their GLP-1 strategy. So next slide, please. And as we're going through, I think Heath mentioned this at the beginning too, but type questions into the Q&A, and we'll kind of pause throughout to answer those as well. And then there'll obviously be time for questions at the end too. Okay. So the super high level background is that obviously the names Ozempic and Mounjaro are probably familiar to you. Those are the two big ones for the treatment of type 2 diabetes. And then there is Wegovy and Zepbound, where Wegovy is the exact same medication as Ozempic. It's just a higher dose. And Zepbound is the exact same medication as Mounjaro. It's just a higher dose. And the Wegovy and the Zepbound at the higher dosages, those are indicated for weight loss. Now, Ozempic and Wegovy are made by Novo Nordisk, which is actually from Denmark. Most of you probably already knew that, but Denmark has two things. It's got Legos and Novo Nordisk. And then Mounjaro and Zepbound are made by Eli Lilly, which of course, as you know, is based in Indiana. Now, the current spend for GLP-1s is about 7 to 9% of total RX spend for employers. Now, keep in mind that RX spend has increased from 21% of total plan costs. Because I used to always say, yeah, your RX spend is about 20% of your total health plan spend. It's about a fifth. Well, it has made some, and many of you might have seen this in the claims over the past year. It's really made a dramatic jump where it's gone from 21% to 27% of total health plan spend just from 2022 to 2023. So that's not all from GLP-1s, right? There's a lot of these monoclonal antibodies and other specialty medications that are also contributing to that. But that's a huge jump in RX spend. So if you do the math on that, if you take, roughly 9% times the 27%, that means that GLP-1s are constituting about 2.7%. So almost 3% of total plan spend is on GLP-1s. Okay, so I would put that in the category of it's a deal. It's not a small deal. It's not a huge deal, but it's a deal for sure. Now, here is where things get particularly exponential, in my opinion. So there are 12% of US adults that have type 2 diabetes. And oh, by the way, the type of diabetes that you're treating with these, it's type 2. It's not type 1, right? So type 1 diabetes, you have to treat with insulin. But this is for type 2. And as all of you know, the vast majority of people with diabetes have type 2 diabetes, not type 1. Now, 42% of US adults are obese. Okay, now here's the kicker. Only 1.7% of plan members are on a GLP-1. In other words, that almost 3% of total plan spend is only being driven by 1.7% of plan members being on a GLP-1. Okay, keep in mind, 42% of plan members are obese. Now, of course, every plan is going to be a little different, but if your plan essentially has the average rate of obesity as the rest of America, then 42% of your plan members are going to be obese. So in other words, if only 1.7% are on a GLP-1, that means only a small fraction of the people who are eligible for a GLP-1 are actually on a GLP-1. So if you do some basic math on it and you take the 42% and you divide it by 1.7%, and you say, okay, what if everybody who's obese was actually taking a GLP-1? Well, that would be a 25x increase in the prescribing rate of GLP-1s. And if you take that 25x increase times the 2.7% of plan spend that you have now, that would be a 68% increase in total plan spend. Now, total plan spend, not the out-of-pocket costs, but just the premiums, claim, et cetera, that are paid by the plan and the employees, is about $15,000 per employee per year, per employee on the plan or per subscriber, right? So if you have 100 employees on the plan, it's about $1.8 million on average that group is spending, medical and RX combined. Now, of course, that group of 100 is going to have 200 members, right? Because we're just talking per subscriber. So we're talking $1.5 million for 200 members or 100 subscribers. And so that's if you multiply that by and increase it by 68%, then it goes from $15,000 an employee to $25,000 an employee. So we're only getting warmed up, is what I'm trying to say. This is barely the first half of the first inning of people being on GLP-1 medications as it stands today. Now, let's go on to the next slide. And it looks like we already have some questions. And so, Heath, if you want to read them or if you want me to read them, either way is fine with me. Heath, are you on mute?
I was saying I'll run out of things to do if you don't let me read them. So let's see. Well, there's one about sharing the slide. Yes, we will share the slides. What is the average rebate offset on GLP-1s?
Oh, I'm so glad you asked that. Because that gets us literally to this next slide. So the average cost per person per year after rebates is $9,000 to $10,000 per person per year for each of these medications. Okay. And they're all about the same. The Ozempic, the Wegovy, the Zepbound, the Mounjaro, they're all about the same. So in terms, I don't really think of things in terms of like the actual percent or the dollar amount of the rebate, because all they're doing is doing it off of some sort of like fictional number of AWP to begin with. So just know that if you as an employer are getting your rebates all in, you're still paying about 9,000 to 10,000 per person per year to be on one of these medications. So good question. And then before I go on anymore, is there another one there?
There was one about whether it was going to be recorded. It is being recorded, and we will post it for everyone to rewatch. And I'll put the link on where you can find that in the chat here in just a minute. So,
okay, super. Okay, interesting. To then go on with this slide. Interesting fact: 82% of the patients who are taking GLP-1 medications are female. So just when we talked about this being the tip of the iceberg, we're not even hardly touching the men yet. So just wait until the men start taking this as well. And then you're really going to see the increase in the utilization. Okay. Now, interestingly, 41 to 51% of patients who started taking a GLP-1 medication are still taking it after 1 year, which to me was surprisingly low. I thought that more people would have stuck with it. But in fact, essentially a little less than half of the people actually stick with it. Okay, so what are their reasons for stopping? Well, one of the reasons is for the side effects. And so one of the one of the challenges with these medications is that they are causing a lot of muscle loss as well. And some people might be stopping them because of the muscle loss. Another problem is they're causing a lot of really delayed gastric emptying, so the food's not leaving the stomach. And so for some people, if they're having it's more of an acute need, but a lot of times, like the anesthesiologist, if you're going in for surgery, the anesthesiologist is having you stop your GLP-1 like 2 or 3 weeks before the surgery because they want to make sure your stomach is totally empty before the surgery because they were having some problems with that. But also, too, a lot of people are just stopping taking them because it's ineffective. And this is super important to understand them. And many of you probably already know this, but the mechanism of how GLP-1 medications work is they work as an appetite suppressant. And all of the studies on GLP-1s that show, better glucose control in diabetics and lowering hemoglobin A1C and weight loss, all of those studies, because I looked at the methods for all of those studies. And what's interesting is that the methods were actually like all very similar, where all the study participants had to have a negative 500 calorie a day diet. And there's 7 days in a week. And so the 7 times the 5 is 3,500 calories. And guess what? 3,500 calories is 1 pound of fat. And then the people also needed to exercise a minimum of 30 minutes daily. So these medications do not work by magically, there's like the law of physics, like matter can neither be created or destroyed, right? So you can't just like literally just evaporate the fat. So you literally have to decrease your caloric intake. And then you also have to exercise. And then the way that we literally lose weight is we literally exhale it in the form of CO2, right? We don't pee it out, we don't poop it out. We exhale it in the form of CO2. So there is no medication that causes you to lose weight without decreased caloric intake. And these medications are no different. You have to have the decrease. Now, they facilitate decreased caloric intake because they act as an appetite suppressant. You're not hungry. Okay. Anybody who's tried to lose weight knows that decreasing your caloric intake is hard because it makes you hungry. And being hungry is miserable. And so this way it's like, oh, well, I'm not hungry. So that makes it much easier for me to do caloric restriction. But there's a problem because people eat for all sorts of reasons, right? Some people eat when they're stressed out. Some people eat because they're depressed. Shoot, I eat when I'm tired. Like eating help keeps me awake. Like I won't be hungry at all, but I'm like really tired. So I'm like, well, I'm just gonna eat. And so if you're eating for reasons other than because you're hungry, then the medication is not going to work. Okay, so I thought that was interesting in terms of people stopping the medications. Now, and as you probably have seen on the high RX spend list for your clients, if you're a consultant or a TPA, that 2 out of the top 4 medications on employer drug spends are typically a GLP-1. Next slide. So, what are various cost containment strategies that employers and brokers and consultants and TPAs are putting in place for GLP-1s? So one, as you can imagine, is prior authorization. And so, believe it or not all plans even require prior authorizations for GLP-1s. I mean, it's the minority, but some plans are still like, oh, if your doctor prescribes it, then you're set. You're good to go. But the majority do have some sort of prior authorization. For the diabetes, because there were a lot of people, and you probably heard about this in the beginning, who were taking Ozempic just for weight loss and they didn't have diabetes. And so they're saying, look, if you're going to get a Ozempic or a Mounjaro prescription, then you have to have, and it can't even just be the doctor documenting that you have diabetes. You have to have, because, obviously these telemedicine companies, it's like, oh yeah, you got diabetes, sweet, let's get you a prescription. So they're actually requiring a hemoglobin A1C lab value to confirm a diagnosis of diabetes before they're allowing the payment of the prescription of the Ozempic and the Mounjaro. And then interestingly, for weight loss, there are some plans that are even putting in place specific BMI level requirements. So above 25 is overweight, above 30 is obese. But sometimes they'll even say, well, you got to have a BMI above 35 or a BMI above 40 because we're going to reserve these very expensive medications for people that are even more sort of down the spectrum of obesity. But isn't this interesting? Look at this next bullet here. The pharmaceutical manufacturers will withhold the rebate money if a BMI requirement is put in place by the plan. In other words, they're twisting the plan sponsor's arm and they're saying, oh, you want to put in a BMI requirement? That's going to cost you. And so your cost per prescription is going to go up. It's going to be higher than the $9,000 per person per year because you're not going to get those rebates anymore. And of course, the PBM is all on board with this, right? Because they're not passing through all of it. They're keeping some of it as well. And so all of you know this is another topic for another day, but the PBMs are financially aligned for your RX spend to go up, not to go down. They're essentially a sales and marketing arm for the pharmaceutical industry disguised as a quote unquote rebate. So just know that this is an option for a plan, but it's an option that has financial consequences that obviously most plan sponsors don't like, but that that Eli Lilly and Novo Nordisk are really kind of socking it to folks. Okay, next up, some groups are putting in step therapy. Oh, I'm sorry. When I said next up, I just meant lower on in the slide. Sorry about that. Some groups are putting in step therapy, saying that you have to use other weight loss therapies that are less expensive first before you can go and try a GLP-1. And then other groups are even saying, look, forget about even medication as a first step. We'll use behavioral and nutritional approaches to weight loss. There's a consumer brand out there called Noom, Noom, that you might have heard of that people can just sign up for their own. It's not an employee benefit, but there's a variety of behavioral approaches and nutrition approaches to weight loss as well. And some employers are saying, hey, look, you got to do one of these things first before we're going to, pay for a GLP-1 medication. And then a third strategy is just increasing the cost share, whether it's on it's a specialty medication, they'll make it a higher co-insurance level. So for every single prescription, if they're paying $800 a month, let's say, that instead of paying 20% co-insurance, they're paying 30% co-insurance on that $800 a month. Or some employers, and actually the Mayo Clinic for their own employees. So for the nurses and the techs, et cetera, that work at the Mayo Clinic, the Mayo Clinic itself put in a maximum lifetime benefit for GLP-1. So they said, okay, yeah, sure, we'll pay for it, but they capped their risk. And they said only up to a certain total number of dollars over the entire time that you're on our plan are we going to spend this money. So at least they could make projections that are capped around how much they would be spending on GLP-1 medication. All right, now let's just talk about flat out non-coverage, because non-coverage is also a cost containment strategy that employer plans are turning to. So now, interestingly, 57 to 96% of plans are covering GLP-1s. So in other words, the Ozempic and the Mounjaro for type 2 diabetes. It seems like a pretty broad range. Why is that? Okay, so it tends to be the large group and jumbo employers that are at the 96% end. And then it tends to be the more smaller mid-market employers. Again, this is self-funded, all self-funded, but more like your self-funded groups of like 200 to 2,000 that are going to be closer to the 57% level for covering GLP-1s for diabetes. Now, for obesity, it's all shifted down. It's all lower. 34 to 67% of plans are covering GLP-1s. So the Wegovy and the Zepbound for obesity. And again, it's really the large group and the jumbos. There's some big states that are like, we're not covering this anymore. I think it was North Carolina for their state employees is like, we're just not covering these medications anymore. It's just financially unfeasible. And then again, for the 200 to 2,000, it's only like a third that are actually choosing to cover these medications. All right, let me pause again and let's see if in the chat or the questions, what stuff is there.
All right, so we had one just come in. What about those who allow it for heart disease?
Yeah. So interestingly, that is such a new indication that there has not been an employer survey based upon that. So I just think that the educated guess there would be that it's probably similar to the because the percentage of folks on an employer sponsored health plan that have heart disease is also, it's frankly, it's fairly low. Like the 42% that have obesity, the percentage of folks that have heart disease is low. In fact, it's probably even, it's lower than the 12% that have diabetes. So there has not been, to my knowledge, there hasn't been a survey of employers specifically asking them about their heart disease coverage, but it probably mirrors the levels of the type 2 diabetes coverage. Good question.
So I think we hit on this earlier, but I hadn't opened up the chat section yet, and this one snuck in through the chat. But as a reminder, please use the Q&A, guys, if you can. Is GLP-1 a first-line treatment for type 2 diabetes now?
Yeah, so that's a good question. And the short answer is no, it's not. And really, first line treatment for type 2 diabetes is a medication that's been around for decades that's called metformin. And you can take metformin. The important thing about metformin is that one, it's super cheap. Two, it works. But I'll just tell you clinically, here's the reason why. This is more than you want to know, but I'm going to tell you in the weeds. Okay. Metformin has a very distinct side effect when you first start taking it. And that is when you first start taking metformin, it tends to make you nauseous. And that nausea lasts for about 1 to 2 weeks. And that nausea increases at a higher dose. And so the key to starting a patient on metformin is you start them on a very low dose, which is like 250 milligrams once a day or 500 milligrams once a day. And then you increase it to twice a day, and then you increase the dosages that you're giving to people twice a day. So what happens is that sometimes the doctor will prescribe them too much metformin to start. They'll prescribe them like 1,000 milligrams twice a day to start. And they'll take it and they're like, oh, I'm horribly nauseous. I can't take this metformin anymore. I need to take a GLP-1. And I'm like, no, 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 no. Or you have to prep, you have to set the expectations of the patient to be like, look, you're going to take this 250 milligrams and like, we're going to try to minimize the nausea as much as possible. It might last for a week or two, but it goes away and people get over it. And so it's really a travesty that really one of the best medications for diabetes that's been around for decades is tremendously underused because it's just not dosed or taken appropriately. So anyway, that's a long-winded answer to your question. But that's why primary care is just so important, and continuity with a physician and a relationship is so important. And we'll get into that a little bit more. But before I get too long-winded, let me stop.
All right, another question came in here. Do you know anything about the trials being done for sleep apnea?
Specifically with GLP-1s, no. But frankly, I wouldn't be surprised if it worked. Because at the end of the day, the most common type of sleep apnea is obstructive sleep apnea. And guess what? The best not so the treatment for sleep apnea is a CPAP machine, this breathing thing you breathe in at night. It forces air in while you're sleeping. You're probably familiar with it. A lot of people hate it because they don't like wearing this mask at night. The best long-term treatment for sleep apnea is weight loss, because what causes the sleep apnea is that when you're sleeping at night, when you're obese, you not only have obesity like around your legs and your buttocks and your abdomen, you also have obesity in your neck and in your throat. And so it's literally the fat when you're laying down flat and you're sleeping at night, it's the fat in your throat compressing your airway that causes the apnea, which causes you to stop breathing. It's a collapse of your airway, frankly, from the fat in your airway. And so I wouldn't be surprised if GLP-1s actually reduce obstructive sleep apnea as well. Again, weight loss and exercise. Guess what? Newsflash: weight loss and exercise are magical. Weight loss and exercise are so good for us. It's like unbelievable. Like I'll spare you, but I could have an entire 6 Degrees health talk about why weight loss is so good for you and why exercise is the most magic pill on the planet. So yeah, I mean, if the study hasn't been done yet, I'm sure it's coming.
All right. A follow-up question to a comment you made earlier, and I think it was in regards to the state of North Carolina, but did Dr. Eric Berkeley just say a plan is allowed to remove GLP-1s from a plan completely or just for weight loss?
Yeah, you can remove them completely. I mean, if you don't want to cover the medications, you don't have to cover the medications. So like there are groups right there, right? So there's 57% of smaller self-funded groups that cover it. So that means that there's 43% that don't cover it for type 2 diabetes. And that's also in the same group of folks that are not covering it for diabetes. So yeah, so there's some plans that just don't cover it at all. And in fact, like think of it, if anything, and this kind of gets into a later topic, is that honestly, I think that these GLP-1 medications, frankly, will be a major impetus for groups to go self-funded. Because right now, are you going to be able to buy a fully insured product that does not cover GLP-1s? The answer is no, because the health insurance company wants the people on the fully insured plans to take GLP-1s because they're making tons of money off the rebates. And so those fully insured plans are going to become more and more and more expensive. And so a lot of employers will be like, well, forget it. I'm just going to go self-funded so I can carve out my GLP-1s and not cover them. So, I mean, that's one of the beauties of self-funding is to be able to be flexible. And obviously we're on a 6 degrees presentation. You don't need me. It's like preaching to the choir. You don't need me to tell you about the benefits of self-funding.
Yeah, I mean, on the not to jump on that bandwagon, but I think most people on here probably understand the benefits of self-funding, customization you can do, and obviously it allows you to do solutions like what we handle with cost containment and RVP. But question here: what if you have a slow metabolism due to a thyroid disease? Does that impact anything on these GL1s?
Yeah, so that's a great question. And so that's where the effective treatment of thyroid disease and hypothyroidism and metabolism, in my opinion, this is just my opinion as an internist, and what I've seen from my endocrinology colleagues, is to effectively treat the hypothyroidism because thyroid hormone does more than just regulate your metabolism. Thyroid hormone has incredible impacts, frankly, on how your liver creates cholesterol independent of your metabolism. If you don't have the right amount of thyroid hormone, then you're going to be creating more bad cholesterol from your not from your diet, just from your liver than you should be. And there are effects on your skin. There's effects on your nervous system. So I think that the correct and the treatment of hypothyroidism is very tricky. And so just because you're underneath the care of a endocrinologist does not mean that your thyroid is being adequately treated. And so like at Johns Hopkins, where I did my residency, like you had doctors that were specialists in endocrinology, but then they were subspecialists in only thyroid disease. So they didn't do anything with the adrenal glands. They didn't do anything with sex hormones. All they did was thyroid disease. And so I would just say that the adequate treatment for a slow metabolism is to actually get your thyroid hormones, your Synthroid or whatever it is that you're taking, and have that have a second opinion or even a third opinion from an endocrinologist to have that appropriately treated.
All right, no new
Great question.
questions have
Thank you.
come in. Yeah.
Okay, super. Thank you guys. That was great. Um, Next slide. So all of this hinges upon caloric restriction and weight loss. Like that's how it works, right? Like of course we want people's diabetes to be better treated. Of course we want people's heart disease to be better treated. Of course we want people to lose weight and not be obese anymore. I mean, just the gravity alone from the weight is incredibly detrimental to our joints, and it accelerates osteoarthritis. So even if you're like you don't have any diabetes, you're totally metabolically healthy, but you're still overweight, like you still want to lose the weight because it's putting so much pressure on your joints. And so really we gotta if we're gonna talk about weight loss, we gotta talk about weight gain. Well, how'd the weight get there in the first place? And some of you are probably familiar with an endocrinologist at the University of California in San Francisco, UCSF, named Dr. Robert Lustig. And he was really one of the pioneering physicians who really was like, look, it's coming from the sugar and it's coming from the high fructose corn syrup. And that's where the obesity and the diabetes is coming from. And the sugar and the high fructose corn syrup cause metabolic dysfunction and fatty liver disease. And it's the metabolic dysfunction and the fatty liver that then cause insulin resistance. Okay. So type 2 diabetes is insulin resistance. And that insulin resistance comes from a fat liver. And that fat liver comes from sugar. Sugar is the culprit. And independent of diabetes, sugar itself causes hypertension. Independent of the diabetes, sugar causes cardiovascular disease. And so we were told, and frankly, it's one of the huge missteps of medicine. We were told carbs and sugar are fine. We just need to stay away from saturated fat and cholesterol. And that turns out to be 100% not true. So Dr. Lustig talks about, you probably remember these cookies from the 90s called Snackwells that were quote unquote fat free, and they're supposed to be good for you. They were filled with sugar. And so the reason why, I'll just very briefly say this, the reason why sugar is so bad is because sugar is made of two molecules. It's made of glucose and fructose. And it's the fructose that makes it taste so sweet. That's why bread, which is glucose, doesn't taste as sweet as sugar, because sugar's got the fructose in it. And glucose is metabolized by every single cell in your body, but fructose is only metabolized by the liver. So all of the sugar and all of the high fructose corn syrup that you eat, it gets slammed into your liver. The glucose is used by every cell in your body, so it gets spread out. But there's this huge concentration. You're just overloading your liver with this fructose. And that liver overloaded with fructose is then what causes the insulin resistance and the type 2 diabetes. Okay, but you're like, but sugar tastes sweet. I mean, of course it does. And it stimulates dopamine in our brains, which then causes it to be addictive. So we get a sugar high, it drops us down, it makes us feel worse, and it makes us crave more of it. And believe me, the food industry knows this. The food industry intentionally increased sugar in their foods because they knew people would eat more food if they put more sugar in it because it's addictive. So guess what? Ironically, one of the keys is if you want something sweet, you eat fruit. Now, I am not here today to tell you that fruit is going to solve all the world's problems in metabolism, but you can absolutely eat fruit if you want something sweet, and it's totally healthy. And immediately, all of you will accurately say, but doesn't fruit have sugar in it? Doesn't fruit have fructose in it? And the answer is yes. But fruit also has something else in it, which is fiber. And fiber, believe it or not, prevents not all, but it decreases the amount of glucose and fructose from the fruit that's absorbed into your body. So you just poop it out. So you still get the sweet taste. You're like, these cherries, these oranges, this banana, it tastes wonderful. Yeah, you still get the sweet taste in your mouth, but you don't get it all getting shoved into your liver because it doesn't all get absorbed because of the fiber. So in the same breath, I'll tell you, so fruit juice is not okay because fruit juice has all the sweetness without the fiber. So you got to have the fiber. You got to have both. And so, believe it or not, increased fruit consumption actually has a 6% decrease in diabetes. They used to say, oh, people with diabetes, they can't eat fruit. Not true at all. Now, there are certain fruits you should stay away from. Like you should probably stay away from grapes if you have diabetes. But there's gobs of fruits, pears, apples, oranges. You can totally eat if you're diabetic. Eating fruits also decreases heart attacks, and it also decreases blindness from diabetes as well. Get this, only 12% of adults actually eat their recommended daily allowance of fruit. 12%! 88% of Americans don't even eat 2.5 servings of fruit a day. We're huge under consumers of fruit. So yeah, of course, people are like, eat your vegetables. That's what your mom says, right? A lot of people are like, well, I don't really like vegetables. Fine, let's start with fruit. At least eat that. All right, next slide, please. So you're like, okay, well, we've tried this in the I'm sorry, go ahead.
Oh, I was gonna say a couple of questions came in. I was gonna make a
Okay, go
comment
ahead.
though. The fruit thing. I like my fruit, but you don't usually see it on a menu. If you think about your general lunch and dining options, you don't ever see fruit there. Okay, Jackie Lynch has a question. Can you comment on honey in regards to sugar?
Yes. So honey is the equivalent of sugar. So it's metabolically, it's the same thing.
Okay. Um, Also, does sugar feed into cancer cells? I have a friend that just was diagnosed with endometrial cancer.
So there is absolutely a connection between eating sugar and diabetes and higher rates of cancer. And the reason isn't necessarily because of the sugar itself, but it's because when you have insulin resistance because of your liver, your body has to create more insulin to overcome that insulin resistance. So people who have type 2 diabetes actually have higher levels of insulin in their body. They're just resistant to it. Insulin is also a growth hormone. Insulin doesn't just cause sugar to go from the bloodstream into cells. Insulin causes growth, and it causes growth of healthy cells, and it causes growth of cancerous cells as well. And so, yes, actually, insulin resistance is a risk factor for cancer as well. It's a very good question.
Okay. There's a question, but it's more of a comment about the honey situation. So Jackie appreciates the feedback.
All right. Well, good. Super. Thank you for the questions. We'll go. So we've tried, we're like, okay, we tried wellness like in the 90s and the early 2000s. Like we tried all this wellness stuff with employers for a decade, more than a decade, and it didn't work. Totally right. I'm not here to argue that at all. But what's interesting is that being able, listen, we still want to achieve weight loss. Okay. So then the question becomes, have employers used a different approach to weight loss than what was historically thought of as a wellness program? The answer is yes. And really, the employers that have had success with getting their employees to lose weight have really been around the folks that use on-site and near-site clinics. So in other words, they delivered that strategy for weight loss, not through a wellness vendor, but through the clinician, through the doctor, the nurse practitioner, the physician's assistant themselves in the clinic. And notice it wasn't through the primary care doctors within the existing fee-for-service community doctors, because get this, point number one, 90% of fee-for-service primary care physicians believe that nutritional counseling is pointless. So they don't do it. So if you think, oh, well, we'll just get people to a primary care doctor and they'll get counseled on nutrition and they'll lose weight, wrong. It will not happen, because in a fee-for-service environment, the incentive is to make those visit times as short as possible so that you can see as many people as you can, so you can bill as much as you can, so that you can make as much money as you can. Whereas in on-site, near-site clinics and direct primary care, it's a subscription model, and the visit lengths go from 15 minutes to 45 minutes, so you can actually have a conversation around what's going on with the person. Well, listen, if the person's depressed and they're eating because they're depressed, well, then shoot, treating their depression and their anxiety is central to their weight loss. If they are living in a situation where they just don't have access to healthy food, well, then that's a we used to troubleshoot this all the time in the clinic at Hopkins. So like it's not just about like browbeating them to eat healthier. You have to really have to go. The process is called motivational interviewing. You have to go through this process of motivational interviewing with the patient to actually figure out what's going on. So employers, not all employers, obviously, but the employers that have put in place these on-site, near-site direct primary care clinics have had success. So one of them is called Serigraph. It's the CEO of Serigraph wrote the book, The Company That Solved Healthcare. The gentleman who wrote it is a man named John Torinus, Torinus. And this book came out like 15 plus years ago. They put in a zero out-of-pocket cost on-site clinic that had a nutritionist and diabetes educators in addition to a nurse practitioner. And they had these long visit times. And then they actually measured the individual's progress in terms of their weight loss. And then they de-identified it. And they had literally management level, executive level dashboards on the weight of the people in their health plan. And they had about 1,000 people on their plan. It was like 500 employees, 1,000 folks on their plan in Wisconsin. And so they just like you have dashboarding for like inventory and all sorts of other things in relation to manufacturing. It's a manufacturing company. They had dashboarding related to obesity and weight loss. They put in an incentive program. They first tried giving employees $400 for compliance with the weight loss or adherence to the weight loss program. Didn't work. So they asked the employees, well, we're trying to pay you to lose weight. Why is it not working? And they said, well, instead of the money, we'd actually rather have days off. I said, oh, okay. You want time off? We'll give you time off. So they gave them 2 days of PTO if they were compliant or adherent with their weight loss plan through the clinic. And they actually had tremendous success, not only in weight loss for their employees. And John Torres says, look, people in Wisconsin, it's the land of beer, bratwurst, and butterfat. He's like, look, our diet in Wisconsin is not great. Nothing against anybody from Wisconsin if you're on this call. But he's like, look, people in Wisconsin, our diet is not great. But they were able to keep their health plan spend flat for 9 years, and doing weight loss through their clinic was one of the strategies they used in conjunction with other strategies. Okay. And then interestingly, in regards to behavior modification, the University of Colorado actually did a study to try to get people to increase their fruit and vegetable consumption, where they would pay them $1 per serving per day. So if you get, all 5 of your servings, 2.5 of fruit and 2.5 of vegetables, they give you $5 a day. And they found that they needed to pay the person, that they would log it. It was self-reported. They had to log it, and then they would pay them the next day. They gave it to them like Venmo or something. And they had another group where they didn't pay them, and then they had a third group where they paid them like quarterly. And the quarterly didn't work. You had to pay because you needed to have the reward close enough to when you actually performed the behavior. So you needed to eat your 5 and then get your $5. Eat your 3 and then get your $3. They couldn't just add it up. So administratively, that's more difficult, right? Just to make it easy administratively, we're like, oh, we'll just do it once a quarter. Doesn't work. So in thinking about incentive programs, it's interesting to see how PTO as an incentive was effective, and also the timing of the incentive was just as, if not more important than the dollar amount on the incentive. Next slide. And there are all the sources. So you asked for the slides. So if you want to look up the sources, then you've got lots of links that you can look at as well. Next slide. And I think the next slide, I think, is just questions. Yeah. So you folks have done a fantastic job asking questions. So thank you so much for listening. And certainly now at the end here, if you have any more questions, feel free.
Anybody else have any questions they want to throw out there before we wrap things up?
And then Heath, if you want to, I sent you a couple of questions too, if you want to ask.
Yeah, I had a couple that you had here. What do PBMs think about GLP-1 medications?
Yeah, so GLP-1s, as you can imagine, any expensive specialty medication is fantastic for PBMs. So they see this as a fantastic revenue opportunity for them. And what's interesting is that, it's just Express Scripts, Caremark, and OptumRx, right? There's really just 3. That's all we're talking about here. I'm not talking about transparent pass-through PBMs. I'm just talking about the big 3. Like Cigna shouldn't be called Cigna, because the majority of Cigna's revenue is in PBM revenue from Express Scripts. So Cigna is a PBM that just happens to have an insurance arm. It's not the other way around. And so they talk very publicly to their investors, because obviously their investors are like, they're very interested in these companies making more money to see if they can, justify their investment in them. And so these companies are actually very open about their strategy. So if you ever want to know what the strategy of a health insurance company or PBM is all you have to do is just listen to one of their investor calls, because they'll tell you. And the Cigna investor presentation, they have these investor days or whatever. The Cigna investor day was like, we see huge growth in our PBM business. They're hugely optimistic about the growth of their PBM business because of the growth of these expensive medications. So they're very much in favor of them. Thank you for your question.
Can you tell us again about the side effects that are happening? I heard you say food is not leaving the stomach efficiently. Is that accurate?
Yeah, it's called delayed gastric emptying. And so they have found that when some of these people that are on GLP-1s have, for whatever reason, have had to go in for surgery, that the anesthesiologists have found that their stomachs have been full. And the reason why you don't want to have a full stomach when you go in is because when they put you under for anesthesia, they don't want you to vomit and then aspirate your vomit, which can potentially kill you. I'm sure many of you know that's how Jimi Hendrix died, right? So they don't want to. That's why they want you to not have anything to eat after midnight. And they found that even when they were like, well, don't eat anything for 24 hours, and it still wasn't enough. And they were like, well, don't eat anything for 2 days, and it still wasn't enough. And so that was problematic for now. Obviously, the vast majority of people that are on GLP-1 medications, like they don't need to go to the operating room, but just know that has been a problem.
All right, we got questions flying in now. Do you have a prediction on which way employers will shift? Will this drive the move towards self-insuring and continue to limit the amount allowed, in your opinion?
Yeah.
Will this be
Yeah.
enough to drive change in pricing?
I think that's the short answer, right? So the short answer is yes. And so really it's in that, kind of 100 to 500 space where there's still a significant number of fully insured groups or maybe even level funded, where frankly, those groups, a lot of them probably, do all of them need to be self-funded? No, but a lot more of them could be self-funded. And so it is depending upon how significant the expense from the GLP-1s is, and also the economic environment of the country, right? So we saw major changes in employee benefits to the consumer directed health plan back during the great financial crisis of 2008, 2009. So if for whatever reason there's a recession that causes decreased organizational revenue, that's when you have people from outside of HR start knocking on HR's door and be like, look, this isn't working. Whatever we've been doing, we can't do it anymore. And it's got to change. So typically there's some sort of catalyst. So between the GLP-1s and if and when there's a recession, that I would imagine that increased self-funding would probably go along with that.
Are compounded GLP-1s medications safe?
It's a great question. The answer is unknown. And so in that situation, like I personally wouldn't take something that is unknown like that. In my opinion, the risk is too much. I personally, you can do whatever you want. I personally wouldn't do it.
Regarding stopping GLP-1s, is there a safety issue with restarting? I've heard this, but don't know accuracy of the statement.
Yeah, that's a good question. And honestly, there has not been like a study on that. So all the studies have been, you've never taken GLP-1s before, you're randomized into either taking a sham shot, like a placebo shot, or the actual shot, and then they study you. So to my knowledge, they have not done a study about starting and stopping. To your point, a study like that probably needs to be done, because if that's the real world experience of people starting and stopping, then it would behoove a study to see what happens when you do that. I think that's a good point.
Are there studies going on to determine if GLP-1 medications increase spend due to the side effects?
There has not, to my knowledge, there have not been any studies on either increased or decreased spend. Now, there's been a lot of theoretical stuff that has said, okay, well, if you like decrease the diabetes complications and you decrease the obesity, then you're going to decrease your overall claims expense because people aren't going to need to go to the doctor or the hospital or yada yada. That's all theoretical. So I think there's major flaws to that line of reasoning. One of which is just the turnover of the organization, right? So just a lot of companies, if you're getting new people coming on and people leaving, then you're not going to have a stable enough population to see that play out. So maybe employers that have very long tenured employees, so like municipalities, education, utilities, these tend to have employees that stick around for a long time. But if you're like a convenience store chain, or if you're like in logistics or like warehouses, like those employees, they stick around for like 18 months to 3 years. So you're like that turnover is probably not going to allow you to reap the benefits of any sort of weight loss or diabetes control.
As an alternative, any comment on intermittent fasting?
Yeah, so intermittent fasting has been shown to assist in weight loss. It's all just a question of how you're going to achieve the negative caloric state. So the key is you need to be 500 calories less a day, and you can do that through intermittent fasting. But there's other ways to do that as well that are not intermittent. So the key is it's a 500 calorie a day decrease. And for some people feel as though intermittent fasting is a good way to do it, but it's not the only way. And there's some people who try intermittent fasting, so they don't eat for 16 hours and they only eat during 8 hours of the day. But if you eat the same number of calories in those 8 hours that you ate previously, then it's not going to work. So just the timing of the food isn't enough. You have to have the negative 500 calories a day.
All right, we're getting down to the last couple minutes here. Are there any healthcare system-wide changes that may come as a result of the GLP-1 drugs?
Well, this is where, if it gets really bad, this is where by bad, I just mean like hugely expensive. Like, let's say, healthcare costs go from $15,000 per employee per year to $25,000 per employee per year. The question becomes, are the employers just going to say uncle and be like, and obviously the, business roundtable, they've got all the connections in Washington, D.C. Are they going to push for single payer? Because frankly, there's like, we want to get out of the employee benefits health insurance business. We want to put everybody essentially on an ACA plan, and we're just going to get out of the employee benefits business completely. So I think the only way we're going to get single payer in America is if the employers of America want single payer. And then the question becomes, are GLP-1s really enough of a financial burden to cause that to happen? I don't know. But theoretically, it's possible.
All right. Well, we need to wrap up. I know that we got a short end to the presentation today. So, Dr. Bricker, I appreciate your time. I appreciate your energy. Contact information on the screen. You can watch the recordings via the link I put in the chat earlier. And I welcome everybody to join us next month. Lindsay, do we got a slide for that? There we go. We got Ernie Clevenger joining us October 16th at 11 a.m. And that one, we were just doing some planning on it earlier. It's going to be a little bit different. Ernie's going to be interviewing Scott, Ray, and myself. And I think we got Julie Boback joining us as well. So more to come on that. It'll be about the history of PPOs and RBP and all the fun stuff in between. So Dr. Bricker, thank you so much for your time. Wonderful discussion. Hope everybody enjoyed it. Until next month, we'll see you again. Thanks, everybody. Take care.
Thanks, Heath. Thanks, everybody. Bye now.